This is Jenny Leaird, and I'm going to present a plan evaluation for nurse-family partnership. Each year, an estimated 380,000 children are born to first-time mothers living below the federal poverty level. Often they are young, single, and socially isolated, and many of these new mothers don't have a high school education. Nurse Family Partnership offers a service that advocates on behalf of mothers and their babies, as well as gives support to the nurses, local agencies, and communities that rally to their cause. Nurse Family Partnership encourages support at the federal, state, and local levels for funding and policies that sustain and enhance their program. As a nonprofit organization, providing network partners across the country with information, support, and specialized training, they propose that creating a bond with a nurse who specializes in maternal child health will lead to a multitude of long-term benefits in the health of low-income families. This model is being evaluated to see if it lives up to its expectations. The program's hypothesis is that there is a window of opportunity during pregnancy when a mother wants to be the best mother possible. At this point, a mother is driven to overcome obstacles. Nurse Family Partnership is about giving that help. 35 years of testing the premise behind visiting nurse programs was done by Dr. David Olds, PhD, professor of pediatrics, psychiatry, and preventive medicine at the University of Colorado, Denver. Testing was done in Elmira, New York. It then was done in Memphis, Tennessee, and Denver, Colorado. In 1996, the Visiting Nurse Program was revamped and named Nurse Family Partnership. Dr. Olds contends that supporting an infant early on will have a major lasting impact on the child's emotional, educational, and social progress throughout life. The graph shows the rationale for why support during the first 2 years of a child's life is optimal to gain the proposed long-term effects. The Nurse Family Partnership Program is about empowering first-time moms to create a better future for themselves and their babies. The program pairs low-income women with maternal child health trained nurse. The nurse and the women will meet around 64 times beginning early in the pregnancy and continuing through the child's second birthday. The plan's goals are to provide the new moms with the confidence and the tools needed to assure a healthy start for their child and a plan that creates a life that has stability with opportunities that lead to success. The Logic model contends that using specialized nurses to help guide new mothers has the impact of improving pregnancy outcomes, providing sensitive and competent caregiving by parents, and helping parental life course, which will lead to a long-term effect of less child abuse, neglect, and less arrest for adolescents whose mothers participated in the program. I propose that we address the first program goal, to improve pregnancy outcomes by helping women improve prenatal health, which will lead to home visits weekly for the first month of the program and then every other week until the birth of the infant. The nurses will address the effects of smoking, alcohol, and illicit drugs on the fetal growth and assist women in identifying those goals that will reduce cigarette smoking. Nutritional and exercise requirements during pregnancy. They will monitor and promote adequate weight gain. They're going to discuss other risk factors for preterm delivery or low birth weight. Prepare for labor and delivery. Basics of newborn care will be addressed at this stage. Family planning will continue following the delivery. Adequate use of the office-based prenatal care, and then referrals to all other human and health services. The short-term outcomes are a decrease in cigarette smoking by the mom, decrease in pregnancy-induced hypertension, and an increased use of community services. For the newborn, decrease of preterm delivery, an increase in birth weight, and a decrease in neurodevelopmental impairments. Intermediate outcomes: early childhood, that's the 4 to 6 year range, will be a decrease in safety hazards in the home, an increase in stimulating a home environment. They're going to use a home score, a decrease in incidence of injuries and ingestions noted in medical records, an increase in preschool language scale scores, an increase in functioning composite scores, and a decrease in problems with clinical range, the Archenbach CPCL. Long-term outcomes will address adolescents up through 15 years. They expect a decrease in state-verified reports of child abuse and neglect, a decrease in arrests for incorrigible behavior, and then later, following 13 years of the program, the mothers will have a decrease in additional pregnancies and live births, better spacing between the first and second child, decreased months on food stamps, and a decreased arrests and convictions, which will decrease days in jail. This evaluation will be set up to evaluate whether or not these home visits by specially trained nurses in the homes of mothers with low socioeconomic demographics truly will improve health behaviors and deliver healthier children, but will also result in better health outcomes in early childhood and adolescence. This will lead to a decrease in health inequities. Questions that will be asked: how well developed and tested is the program history? Were the objectives met? And are the program's accomplishments worth the resources invested? Overall, we ask if the expansion of a program in Indiana is warranted. How well developed and tested is the program history? A look back at data that has been collected and the types of studies collected will give a good deal of information on how well developed and tested the program has performed. In the past, 40 years of randomized control studies have been performed, and an evaluation for rigor will be beneficial, looking specifically at health equity and how well the plan will bring health equality and equity into play. Were the objectives met? Again, collected data is available, and verification of this data will support whether or not the proposed objectives have been met. Those objectives are decreases in prenatal cigarette smoking, fewer hypertensive disorders in pregnancy, fewer closely spaced subsequent pregnancies. Prenatal health problems and exposures to substances can compromise the health of the fetus, and especially the developing fetal brain. Prenatal tobacco exposure, for example, increases the risk of preterm delivery, low birth weight, behavioral problems, and even adolescent crime, and is substantially more prevalent in low income than in high income women. Preterm delivery and low birth weight, in turn, are the leading contributors to infant mortality. The amount of time between pregnancy also has a strong effect on the health of children. Closely spaced pregnancies, that's pregnancies within 18 months of the previous live birth, are associated with poor birth outcomes. That's preterm birth, low birth weight infants, and neonatal mortality, and reduced prenatal care. Is it possible that a visiting nurse can turn around so many causes of health inequities? How about in the long term? The program contends that in the long term there will be, again, a reduction in child abuse, less behavioral and intellectual problems, fewer convictions of mothers, increase in months employed by mothers, and fewer hypertensive disorders of pregnancy. Again, there have been a plethora of research collected over the last 40 years, randomized control trials, research, and longitudinal follow-up studies, allowing for ample opportunity to investigate the validity of the data as well as the plan's effects. Are the program's accomplishments worth the resources invested? To answer this question, independent evaluations may be looked at to verify that nurse-family partnership outcomes for families also produce significant savings to federal, state, and local governments. We could use a cost-benefit analysis. I would propose an impact evaluation be used to provide evidence for policy and funding decisions. It will show the degree to which the program is meeting its ultimate goal. Longitudinal design with a baseline, midterm, inline testing with follow-up. The data needed will be collected from other sources and will require the assimilation and interpretation of the records for verification. Data will need to be collected well after the program's end. As this program was developed with that in mind, this data has been collected over the course of 40 years, and when assimilated will give a good idea as to whether or not the program has met its ultimate goal. Review of data collected is recommended. The presentation of this evaluation will include a presentation of data from a multitude of sources, condensed to provide an accurate depiction of the facts, figures, and numbers in an easy-to-read, functional manner. The information will be presented with the short-term outcomes presented separately from the intermediate outcomes and long-term goals. Special emphasis will be on the cost-benefit ratios. Overall, whether or not to expand the program will come down to the return on investment. Does a relatively simple investment in pregnancy and early childhood truly lead to an extensive balance in health equity? A nurse who, with special training in maternal child health and a knowledge of local resources, meeting with low-income mothers from early pregnancy through the first two years of a child's life, truly bring balance to health disparity, is worth evaluation, as it is this very upstream effect that public health practitioners are looking for. This is Jenny Leaird, and this is my plan evaluation for nurse-family partnership.